Okay, so I have about 20 minutes to talk about the clinical need of whole body metastasis study, and you see that I have already replaced the word study with MR imaging. That's because MR is what we're going to be concentrating about in this talk, and I'm going to by the by cover the other imaging modalities that we have in our kitty for doing the metastatic workup. What I'm going to do in the presentation is basically divide the talk into two halves. In the first half, we'll discuss what the topic says, that is the clinical situations where we need to do a workup to find out whether there is metastasis or not and what is the extent of the metastatic burden. And towards the second half of the talk, I'm going to share with you all the experience that we have at our institute in the use of whole body MR, particularly for breast cancer patients. Now, the reason to do that is twofold. One is, if you see, whole body MR is a highly underutilized investigation as far as metastatic workup or the oncology workup goes. The reason for that is twofold. Whatever evidence that is there with us today is small. It's usually small studies with few patients, and whatever studies are there are often contaminated by inclusion of patients that are spread over different cancer types. And that's not how cancer care is handled, because you have recommendations for an individual cancer disease. So you don't really have enough data or enough evidence to support a whole body MR investigation for oncology workup. So what we're trying to do is we did the analysis like a pilot study within our institute, and then we try to see whether it's of any good use, and we realize that it is definitely a modality with a lot of potential. We presented this data at a premier radiology conference, and there was a lot of interest generated in it. So I thought that the users meet would be a good idea to share the same experience with everybody. And at the end of the 20 minutes, if there are more people in the audience who have the same infrastructure in terms of the oncology work flow that they have in their institutes and the equipment, then we could probably interact and probably even do a multi-center randomized control trial about this investigation. So let's move on to the clinical needs, and there's one situation where we definitely need to find out how much is the metastatic burden, and that's the time of the initial workup or the TNM staging. Now, as I already mentioned earlier, there are various bodies like the ASCO or the European bodies which have these recommendations for what are the investigations that need to be used for a particular cancer type to look at the metastatic workup. And what these recommendations usually have is a multi-modality strategy. So typically they end up using X-ray chest, ultrasound or CT and bone scan to get the information about how much is the metastatic spread. Of late, there are two total imaging tools that have come up. CT PET, which has definitely gained a lot of acceptance in the oncology fraternity, and whole body MR, which is still, which is gradually gaining acceptance, but is still under evaluation. Let's do a broad comparison between these two total imaging tools. CT PET definitely has the advantage that along with the structural information, you're also providing metabolic or functional information. But the problem really is that most centers end up imaging from skull base to mid-thigh. So is it really a whole body imaging? We are not looking at the brain, which is a major site for metastasis. So it's not truly whole body in that sense. The other thing is, FDG is the common tracer that's being used, and there are some tumors that are non-FDG avid. So what do you do about these tumors? Whole body MR as against CT PET provides only structural information, and you can add on to the structural information by using things like diffusion imaging or by using specific contrast agents. But its real strong point is the fact that it's a truly whole body imaging workup. So you're imaging the patient head to toe. What it lacks really is the cost and the amount of interest that we as radiology fraternity are putting into this investigation. We are so busy doing other things that we think of this as a clinical indication to use our whole body work for as something very low down in our priority. Besides, there's not enough evidence to support or recommend this investigation to our patients and ask for it. And this is one of the reasons, the lack of evidence, that a lot of oncologists would hesitate to support any center which is doing a lot of whole body MR work. Just a little bit of statistics and evidence that is available on the whole body MR imaging as against CT PET. There's only one study that has really actually compared CT PET and MR for the entire TNM staging workup, and I've removed the T and N bit and only talked of the M staging, where they found that both modalities were actually fairly comparable. If you look at an organ-specific approach, one definitely has an advantage over the other. So for the lung, it's the CT PET which scores over the MR, and that's especially for the sub-centimeter lung nodules. As far as liver goes, MR has an advantage over CT PET, and this is especially for the tiny nodules close to the diaphragm. For brain, MR undoubtedly is the best investigation that we have. What about the bone, which is another common site? There is debate in the literature about which is better. Some studies will say that PET-CT is better, and some studies will say that whole body MR is better. But what all these studies would agree with is that both these total imaging tools are far, far superior to what is right now considered the standard of care to detect bone metastasis, and that's bone scan. And as you can see in this chart, the sensitivity and specificity is really high as against bone scans.